Oh yeah, click on the fact that I'm recording. Okay, so hopefully everyone's got what I've got in front of me now, which is the beginning of my slides. So and I'm just waiting for something to drift out the top of my picture. Okay, so I'm going to talk to you today about sort of three interlinked but slightly different conditions. And I was just saying to Gersh before we started, these are things that I think we only see the tip of the iceberg of. I'm not sure that many of the women that experience them actually fully understand that that's what's going on for them. I have PMS or PMDD, and so as I learned about it as I was doing my menopause training, it was like getting my lens in about my own sort of experiences, and having some treatment for it has made a massive difference. So I speak from that kind of position. And it's an area of really evolving science and understanding. Historically, I think doctors have always thought that body stuff happens in the body. So, you know, hormonal stuff is very much a body thing going on, and psychological stuff happens in the brain. And we separated really falsely the two things. We even, you know, have different hospitals for psychiatric problems and body problems and different sets of notes and so on. But we've got increasing evidence that particularly where hormones are concerned, there's direct impacts on mood and behaviours and things. So I find this really interesting. And I'm going to try and share some of it with you today. I'm just going to try and get my slides to actually move because they don't want to move. There we go. Okay. So first of all, I mean, Gersh just explained who I am. I'm a GP by training. I used to work in a hospice for 10 years and I've got palliative medicine diploma background. And I've also been trained in clinical sexology, which gives you psychotherapeutic training. And I had to do 50 sessions of counselling myself as I went through it so that I could actually sort of counsel other people. And it was on the back of that that I did sexual medicine training and menopause training, because I was finding loads of the women and that I spoke to who were having problems with sexuality were women at menopause. So that's kind of where my interest has come from. But as part of that training, I've learned a lot more about psychology, psychiatry, trauma. And I've ended up working in a clinic that works with menopause and PMS and PMDD because there is this overlap. And I'm also involved in a local trauma centre. So just more and more see women where I see all this kind of overlap happening for them. Find it really interesting and really satisfying to identify and treat, because it can have a huge impact. So we're going to try and cover today something about the kind of definitions of PMS and PMDD. So that's premenstrual syndrome. PME is premenstrual exacerbation, and I'll define all of these in the next few slides. And PMDD is premenstrual dysphoric disorder. They're all related, interlinked, but slightly different conditions. I'm going to talk a little bit about how they're specifically impactful as we go through perimenopause and how it might impact the choices that people need to make around HRT or other things that we would use alongside HRT. And I'm going to try and open it up into some of the lifestyle and non-drug approaches as well. Although, as I said, the science is pretty new on this. There's still quite a bit of debate about the best guidelines to follow with it. And if you've got questions, pop them in the chat, and hopefully afterwards we'll have time to go through some of them, and I'll do my best to answer. So if we just start with some kind of definitions and some understanding about what these things are. And I'm always fascinated. I had barely been taught this as a GP, and I was doing women's health, and I had barely been given any training at all on this. And like anything, once you get your lens in, you see it everywhere. So just understanding it, I think, is really helpful. So in the last 5 years, maybe more, we have started to understand a little bit more about this idea that we can group conditions into reproductive depression. So that female hormones have a direct impact, a direct biological impact on mood and brain function, and that some of the conditions that women experience can be grouped together because they have the same biological underpinning basis. So we look at them now as being reproductive depression, and this includes things like changes of mood with hormonal contraception. And I see lots of women who hate hormones, and the reason they hate hormonal contraception is usually because they've experienced a massive change in how they feel on the back of using something before. These women have often experienced antenatal or postnatal depression. And they've often experienced significant change as they cycle through their menstrual cycle. So there's this switching on and switching off of mood change that happens at different points in the cycle. And that's kind of the hallmark. It's the change in our female hormones that then impacts the change in mood. And it's quite important, I think. We talk a lot about hormone balance at the moment, and I keep hearing it in my social media and everything. This is not a hormonal imbalance. The hormones are working normally. What's different is that because of biological changes in the wiring of your brain and your nervous system and the receptors in your brain and nervous system, your body responds very differently to the changes in those hormone levels. So the hormones are balanced, they're working as they should do, but we're responding differently to the fluctuation. There's different estimations of how many women have this, that it varies quite widely depending on which papers you look at, but roughly 5% of women or individuals who've been assigned female at birth will experience premenstrual dysphoric disorder, and that's the most severe symptom cluster, PMDD. And it is a severe negative reaction to natural hormones. So as I say, it's not hormonal imbalance, it's the way that we respond to it. And there are trigger points as we go through life where this can start or it can worsen. So at the beginning of your periods, at pregnancy, after birth, after miscarriages, and at perimenopause are kind of classic times when this can become more problematic. And again, it's a consistency of pattern. So we usually get women to do cycle diaries to help them to identify what's going on. And actually, most of the women I speak to have already been doing it, keeping notes, because they notice a difference in it. And it's like a switch, a switch that goes on where you look at your life on one day and you can cope with things and not feel overwhelmed, and you're pretty happy with your life choices. And then for a period of time, you feel very, very differently about your environment, very irritable, ragey, low, negative, sometimes suicidal ideation. And then usually within a few days of a period starting, you'll flick out of it again and things will feel very different. I live in a very beautiful place. And before I recognised what was going on with my own hormones, I remember going around the dog walk that I do. I live near Fountains Abbey, if people know that, so the Seven Bridges Walk, and feeling incredibly negative and overwhelmed with everything that was happening in my life. And then the next day, going around and just noticing the beauty of all of it again. And it was literally a 24-hour period. Nothing had changed in my life, but my kind of internal environment had changed massively. And that's what women tend to sort of explain to me when they come and see me. So for most people, the symptoms are worse in the days before a period, but you do see women where actually 3 weeks or so of their cycle is problematic. And then things get better within a few days of the bleeding starting, again, really, really quickly. And you have this repetitive sort of patterning. And part of the underlying basis of it is that we know from studies that estrogen kind of beneficially controls loads of the hormones that send messages in our brain and nervous system. And these are all the same chemicals that are implicated in depression. So it's things like serotonin, dopamine, noradrenaline, or norepinephrine, as it's called in the international community, our cortisol, our stress hormones, and this thing called BDNF that I'll come back to later. These are all the chemicals on our body that impact mood and irritability. And estrogen directly is implicated in sort of moderating how they work. And estradiol generally helps our brains to be more plastic, more changeable, and to protect them from damage. So we definitely see this impact. And PMDD is so severe that about 30% of those that have the diagnosis will feel so bad at some point that they'll make an attempt at suicide. So the fact that we miss this in individuals quite consistently and we misdiagnose is incredibly important. So getting that kind of awareness and recognition up, I think, is key. So what are the links that we find in people? Well, again, I was just talking to Gersh about this, that you will look back through families. When you make this diagnosis about yourself, you can often go back and you can start to look at your mum or your dad's mum, your aunts, and track it back through your family, because there's a heritability. Between 30 and 80% of women will have some element of inheritance in this. It's a genetic thing. So you can start to make sense sometimes of the behaviour of women who've gone before you. In my own family, my great aunt was institutionalized. My grandma was on sorts of tranquilizers and things going through menopause. These are really, the diagnosis is really key for some people to make sense. And again, daughters, many women who are going through perimenopause will have a daughter who's starting her reproductive life, and they're also sometimes susceptible to the same mood changes. So having that awareness is really important. And the diagnosis is often wrong, mismade. You'll be told that something else is the matter, such as depression, OCD, bipolar. but often actually the underlying diagnosis is to do with these hormonal fluctuations. We see overlap in women who are neurodivergent, whether they're diagnosed and identified as being neurodivergent or whether they just recognize those patterns in themselves. And we see a correlation with trauma history and a history of depression. So we have these links. And this is just a picture of the menstrual cycle. So anyone that's a clinician watching this will have some kind of awareness of this kind of choreographed dance of hormones that happens during our reproductive lives. But I guess the key thing is there is a zone where women are much more prone to these symptoms if they have PMS, PMDD, or PME, and that is in what we call the luteal phase. So ovulation happens in the middle of the cycle. The sac that the egg comes out of is called the corpus luteum. It's the bit that's left behind. And the luteal phase is the name of the bit where the corpus luteum is secreting progesterone in the second half of the cycle. So these symptoms start to happen in the second half. And two things happen, as you can see from the hormones. There's a rise in progesterone in that part of the cycle, and there's a fall in estrogen levels. And there's some uncertainty as to which of those two bits is the most important. And there's different kind of views and hypotheses as to what causes this, and that kind of feeds into the treatments. But the symptoms happen in that sort of later half of the luteal phase and into the first couple of days of the period, and then the mood normally gets much better afterwards. So this is the diagnostic criteria for premenstrual dysphoric disorder. To get the diagnosis, you need to have at least 5 of the symptoms that are on the screen here, but one of them has to be from the column on the left in the pink. So mood or emotional changes, irritability, anger, or increased interpersonal conflict, depressed mood, feelings of hopelessness, worthlessness, or guilt, and anxiety, tension, of feelings of being keyed up or on edge. One of those 4 is key. And then the others I'll let you read yourself, but it's all the things that many females will recognize. So the low energy, the physical changes, joint aches and pains and bloating, breast tenderness. This impacts our appetite pathways. So we get very specific food cravings and eat very differently. There's an overlap. Premenstrual exacerbation can overlap with eating disorders. So eating becomes much more dysregulated in that part of the cycle. And lots of people will recognize themselves in this criteria. And it's about severity, really, with PMDD and patterning. So we have some hypotheses, and there are guidelines in the UK that help us to understand how to treat these conditions. There are some different ones in the US, and there's centres in Australia, for example, that are doing lots of research into this. One in London that's doing a lot of research into this as well. And we're trying to understand exactly why it happens. As I say, we know there's a genetic element to it. We know that brain circuits respond differently in susceptible women and activate differently when we compare them to those that don't have these conditions. And you can see that sometimes on MRI, functional MRI scans, that different parts of the brain will light up. And there's a breakdown product of progesterone known as allopregnanolone. I'll just call it allo from this point onwards. And allo interacts with the GABA part of our nervous system. So most of you will be familiar with drugs like gabapentin, pregabalin, and they act on the GABA part of the nervous system. And they're chemicals that calm us and sedate us, anti-anxiety chemicals. And our GABA nervous system is activated by alcohol or by benzodiazepines like Valium and barbiturates. It's part of us that normally calms, sedates, and kind of chills us out. But in people that have PMS and PMDD, there are differences in allo levels at the second half of the cycle, and there are differences in how allo works in their bodies. So rather than getting that calming impact, we see agitation, overwhelm, suicidality, anxiety, irritability. And there are lots of sort of studies that show, I'm making a point of the fact this is biological, because I think a lot of women think it's them not coping, just like with menopause. This is a biological underpinning issue that's the problem here. And for many women, it feels like they have 1 week where it's hell, and then the rest of the month they're having to clean up the damage that's happened in relationships because of how they've behaved and how they've felt in that week. This is a horribly complicated slide, so I said bear with me with it. And it was just kind of putting together the studies and the theories. But again, just to underline the genetic susceptibility, the fact that we think the progesterone breakdown products are really important, the fact that we've got lots of research evidence that shows us that estrogen interacts a lot with serotonin and this thing called brain-derived neurotrophic factor that kind of is involved intimately with neural pathways and developing pathways. We know that there may be differences in brain structure, and we know that some of the hormonal regulation we have in our body, so we have something called the HPA axis and the HPG axis, and these are just complex feedback mechanisms where the brain talks either to the gonads that make the sex hormones, or the brain talks to the adrenal glands that makes the stress hormones. And we know that these things are interacted with by our sex hormones, by estrogen. So when our estrogen levels change, we've got hypotheses and pathways that help us to understand why we see these differences in tolerance of stress, in this patterning that we see in people in terms of mood and behavior. One of the theories that's been suggested is that some people are more biologically susceptible to stress. We see overlap with things like PTSD that we don't fully understand, but there's definitely some patterning and overlap between individuals that have trauma history, complex trauma symptoms, and you have these sorts of patterns with susceptibility to hormone change and mood. And again, that overlap with neurodivergent individuals, so ADHD, autism, lots of sort of overlap between these things. So if we put it all together, you know, I guess the key thing is it's hormonal fluctuation that's the issue. It's a body-based issue rather than a coping strategy issue. This isn't something about how you manage your mood and something that's wrong with you as an individual. This is a chemical thing that's making you feel very different in your nervous system for a certain part of the cycle. And it's that fluctuation that's the problem. And we have differing diagnoses. So premenstrual syndrome is very similar to PMDD in terms of the symptom structure, but it's much more common. It's less severe. It doesn't tend to have the depth of depression that goes along with the PMDD cluster of symptoms, and it's not in the DSM criteria. It's not classified as a mental disorder. I hate the pejorative language like that anyway, but at the moment we've got the DSM, and that's what we sort of use to make these diagnoses. Premenstrual dysphoric disorder is much more severe and is under the current classification. We have less people that are thought to suffer with it, so somewhere between 2 and 8%. It's very disruptive to people's lives, and it is classified as a diagnosis in the DSM. It's more complicated for us to treat. It's more impactful and more difficult to treat and control. And as I say, lots of people that work in it say that probably the hallmark is that suicidality, that severity of depth of mood change. And then PME is important to pick out because lots and lots of other diagnoses like eating disorders, OCD, self-harm, anxiety, they will see a period of intensifying at the same point of the cycle in that luteal phase. So the regulation of them gets much more difficult. And it's not quite the same as PMS and PMDD, but it can still be really useful to regulate hormones, even though the primary diagnosis is different. It's an eating disorder potentially, but it's an eating disorder that's getting worse at a certain point in the cycle. So it can still be really worthwhile looking at managing hormones and changing how the hormone patterning is going on in that body. And this is just a quote, really. Again, I think for me, a lot of it is about validating the lived experience for women, that this is something that's incredibly disruptive. If it's only even just a week in your cycle, and for many women it's 2 or 3, we're talking about a quarter of your fertile years or half of your life during your fertile years where you feel like this. So it's something culturally we dismiss mood-related change, hormone-related mood changes. We minimize them, we make jokes about them, and we dismiss them. But actually it's a big chunk of women's lives, and it can have a huge impact on quality of life, and doing something about it can be life-changing. So what can we do about it? Well, like everything, there should be a holistic approach. We should be trying to sort of look at lifestyle, look at behavioural things, as well as looking at drug options and hormonal options. We've got a fairly scanty evidence base because not enough research has been done in this area, and it's growing all the time. we know that CBT and DBT have been shown to improve people's coping strategies and reduce depression for those that have got PMS and PMDD. Just like with perimenopause, we know that aerobic exercise and doing physical activities can help with mood regulation and help with decreasing anxiety. There's benefits in eating a diet that's rich in protein and complex carbs, because they give some of the building blocks of serotonin, which is the hormone that helps to improve our mood. If we take a diet that's rich in sugar and alcohol and caffeine, these fire our stress hormones, these sort of increase insulin and cortisol release, which can worsen some of the kind of stress and irritability. So reducing those is helpful, and being able to regulate sleep makes a huge difference. So sleep hygiene techniques or things like melatonin, where it's indicated, can be really helpful. Like everything, there's lots of talk about supplements, but not always a great deal of evidence. Doesn't mean it's not always that they're helpful. Sometimes it's just that the studies haven't been done, but we do know there's no evidence for vitamin B6. There's some research evidence that shows things like Agnus castus or chasteberry is of some use in cycle regulation, and St. John's wort. And we know that evening primrose oil, unless you're trying to manage breast tenderness, it doesn't really have an impact on the rest of the mood-related symptoms. And the key thing that we try to do when we're treating it sort of away from menopause in particular, so just treating it during fertile years, is to regulate hormones. And the way that we regulate hormones usually is to suppress ovulation, because that patterning up and down is because we release an egg, and the progesterone release is because of ovulation. So if we can stop people from ovulating, then we can usually improve their experience of mood during the month. So the UK guidelines talk about the combined pill as being a way of doing this, but it's not without complication, because many women who are susceptible to these kind of mood changes will not get on with certain synthetic progestins. They'll have particular problems with some of the man-made progestins that may make their mood worse. So in the UK, we suggest Yasmin or Lucette, but in the Australian guidelines, they recognise that the progestin that's in that can actually create rage in some women. And I've had that in patients where I follow the UK guidelines, but actually that the women that I've treated have had a really strong negative response to the progestin that's in Yasmin and Lucette. So Zoe, which has a different progestin, is preferred over there. But this is an easy to access treatment option. Everything you do with these women, there's a chance they'll get worse rather than better. So you have to kind of say that from the beginning, that it's iterative, it's trying things on for size and hand holding and supporting. And it's really individual as to what will work for different women. What we try to do is run the packets together, usually 3 packs in a go, or using it continuously with short breaks where there's spotting, to minimize the amount of hormonal fluctuation that we allow. And sometimes it's helpful to add a little bit extra estrogen on top of the combined pill to top up those levels and improve mood. I also use, in fact, one of the things I turn to the most, because I see a lot of perimenopausal women, is estrogen patches, just like in HRT, but we go high dose. We go for the 100 end of the spectrum, because we're trying to stop ovulation. So if we're at 100 or slightly above that, we've got more chance of kind of stopping the natural cycling that's going on. And then giving a low dose progestin to go alongside it. So I tend to use the Mirena coil, because it's very low dose and it's very constant in women that are still bleeding. But we can use cyclical or continuous progestins in women. I'm going to come back in more detail to options at perimenopause again shortly. SSRIs, I think, have got a really bad rap recently. One of the problems, I think, with the conversation that's happened in menopause in the last couple of years with the Davina documentaries is women feel like they're being fobbed off if they're being offered an antidepressant. And I think if it's menopause-related mood disorder, they probably are. The hormones are the main thing to change. This is slightly different with PMS and PMDD in fertile years and as you go through menopause. There's good evidence for SSRIs being helpful for some women. Sometimes it's useful to use them instead of, or as well as. You can often sort of put the two things together. And we use SSRIs in 2 ways. We either use them just in the luteal phase, so just for 2 weeks on and 2 weeks off, and there's good evidence that that can be helpful, or they can be all the way through the month, but they help to support serotonin levels and keep them high. So some people just don't get on with antidepressants. They get sexual side effects, or they feel that their emotions are kind of blunted and they're a bit numb and they don't like that. So we have to match the solution to the woman. And then again, the sort of level 3 and level 4 options are to induce effectively chemical menopause. So we use GnRH analogues, drugs like Zoladex and Prostap, that are injected monthly. These block hormones at the level of the pituitary gland, and they stop the stimulus to try and ovulate. So they induce a chemical menopause that have to have another injection each month to keep that going. And then what we often do is add back HRT at a low and continuous dose. So we try and, again, smooth out the hormones through the month. We do need to add back hormones usually, because if we don't do that, we're at risk of bone loss. So even sometimes you'll give women a few months to see what happens without adding something in to help to make a diagnosis. But if we go longer than 6 months, then we have problems associated with menopause. We look after hearts and bones, and we have to give hormones back. We often find that women escape control with this if we try and do it for too many years. So often, if this is a successful strategy and the woman is young, we sometimes progress to talking about removing ovaries as a way of managing things going forward if fertility is not needed anymore. So the cure theoretically for this condition actually is hysterectomy and oophorectomy, taking the ovaries and the uterus out. But even in those circumstances, kind of fascinatingly, you get women who'll feel like they're ghost cycling afterwards. So even when the ovaries are gone, they sometimes still feel that patterning. And there's hypotheses around epigenetics and other factors that might explain that. It's definitely something that I see, though we don't necessarily understand why. And again, when you take ovaries out, if you do that under the age of 51, you need to try and replace hormones at low levels, at least, to protect bones. Going forwards from 51, it's like any other menopause. You've got to sort of think about the pros and cons and choose carefully your HRT in these women, which I'm going to talk about shortly. So at menopause, specifically for those who are sort of listening because of menopause, I'll talk about the impacts. So like I said before, there are these kind of key flipping points as women go through life where hormones change significantly, and that sudden change in hormone patterning can either start or worsen PMS and PMDD symptoms. So as we said, as girls start to ovulate, so often the beginning of periods is not too bad, but when they start to ovulate regularly and produce progesterone each month, that's when you start to see the mood changes. I see a lot of women in my GP practice, or young women in my GP practice, where I'll now do cycle diaries for self-harm or anxiety and start to see that there is patterning with their hormones that I would have missed before I wasn't really aware of this kind of thing. I don't think CAMS and other organisations do that routinely yet, but I find that quite helpful with my sort of teenage patients. Pregnancy and birth can obviously be triggers, but perimenopause is a period of just intense chaos, actually, in terms of hormonal regulation in the body, and it can be a really difficult time for women with this tendency. So mood change is very prevalent at menopause. It's high anyway, even if you don't have this background history, that you'll get your first incidence of depression as you go through peri. But for women with this reproductive depression history, this history of postnatal depression or mood change with a pill or PMS, they have a really much higher relapse rate for depression as they go through this period. And overall, we see 16 times the amount of depression in women between the ages of 42 and 52. And this correlates almost exactly with that kind of decline and chaotic function of the hormones in the body at that stage. Interestingly, it's the brain changes that show up first. So women know it's menopause when they get hot flushes. They recognize that, they know what's going on. But it's this, on average, 5 years before your hot flushes that you start to get the change in brain functions. So word finding, cognition, memory, that kind of stuff, but also in brain changes in terms of mood, so depression, irritability, emotional lability. So after menopause, we find that depression rates go down, which again kind of reinforces the theory that it's not the hormones themselves, it's the change, the fluctuation, that's the biggest problem. And we have a problem because women of childbearing age respond better to antidepressants, but we find that they're less useful in women as they go through peri. We don't really understand why. This is a useful chart from a study in an endocrinology journal that just kind of looks at the symptoms and the stages of symptoms happening. So 70% of women will get hot flushes and some kind of cognitive or mood disorder. Only about 30% of women will get only hot flushes. So by far and away, the majority of women going through perimenopause will be symptomatic, and some of their symptoms will be to do with brain function, mood regulation. There's a big part of it for lots of women. And choosing the right HRT is vital, because if we get the wrong form of progestin and we get the wrong patterning of progestin, we can make things more difficult. So if we're giving cyclical HRT, which is what we tend to do with women who are still bleeding, we give them a pattern that mimics bleeds and gives them 2 weeks on, 2 weeks off, 2 weeks on, 2 weeks off of progesterone. For some women, that's going to continue them with that mood patterning where they're having a luteal phase effectively that we're giving them. And so that's going to continue to sort of give them mood change that they can predict as they go through the month. So we need to sort of look at the menu of SSRIs, look at specific forms of HRT that have better progestins, so things that are not synthetic progestins, usually utrogestan or low dose progestins are useful. Using high doses of estrogen through the skin rather than standard doses can be really helpful, because when we get nearer to 100 to 150 micrograms of estrogen through the skin, it's a similar level to what's in the contraceptive pill, which means it's high enough to stop ovulation in women where ovulation is still happening. And if we can stop that, we end up with just the hormones we're giving a woman, rather than layering of their own hormones plus the HRT, and there's still that chaos. It still is lots of change, which means lots of mood change. I use Mirena more in these women because Mirena is low dose and tends to have a more stable sort of pattern through the month. I find lots of women who are in this group are terrified of a Mirena coil because they don't like the idea of having something put into them that they haven't got the option of stopping if they feel bad mood-wise with it. So I need to do quite a lot of counselling around the fact that I will take it out, that I give them warning that it can take a few months for mood to settle with it. The dose is relatively a bit higher in the first 6 months than it is afterwards. But where women accept it, it's often a really good option. And then we've also got the GnRH analogue. So sometimes for those women who are in peri, what we choose to do is stop them ovulating, kind of take control of the hormones and then give them back in a smooth pattern. So as I said before, we need higher doses, 100, 150 sometimes. And where I can do, I use utrogestan if possible, or the Mirena. So utrogestan is body identical progesterone. It behaves differently than other synthetic progesterones. It's usually better tolerated by women. It's usually better to give it continuously if you can do. And if we give it orally, it's got more impact on mood and behavior than giving it vaginally. So vaginal is off license, but we often give the progesterone vaginally in women who are hormone sensitive. So they get that kind of local absorption, but don't get so much systemic mood change. And sometimes we need to do HRT and the antidepressants on top of that, that the two things can make a big difference rather than just one on its own. And as I said, a bit of repetition really, but with women going through perimenopause, if they're struggling, because you end up, the problem you have is bleeding, and trying to get somebody onto a stable pattern of HRT before they're ready to stop bleeding can sometimes give us real problems with spotting. And if women won't accept the idea of a Mirena, then it can be very difficult to get a pattern that controls both mood and bleeds. And that's when you end up heading down the route of the GnRH analogues and the injections that stop ovulation so that we can get a better pattern. And ultimately, there are women for whom symptoms are so severe and impactful that they'll choose hysterectomy. And I think you have to bear in mind that for some women, it's life-saving. When you get back to that stat of, a third of women will attempt suicide, and we know that suicide rates in women are at their peak as they go through perimenopause. For some women, hysterectomy, oophorectomy is absolutely the correct thing to do. So I guess my take homes, which I've hopefully hammered home, is that it is biological, genetic. It's not something that that you can just get a grip of. It's very much something that's happening in a biological, biochemical way. It's absolutely reasonable to seek help for it because its impacts on quality of life and mood and suicidality are significant. And it's vital that if you do have that kind of history and sensitivity, that you pick somebody to treat you that understands PMS, PMDD, and can choose the right kind of HRT regime for you. Because if you get the wrong one, it can actually make things worse. I had a lady that came to me from seeing somebody else. I think she was just seeing her GP actually, but she'd been put onto Everell Conti, but with a history of postnatal depression. And for her, as she flipped from the first half of the month, which was just estrogen, into the second half with a synthetic progestin, she got really strong suicidal ideation. So women have to be aware that they can react very badly to certain progestins, and it's important to kind of have that knowledge going into choosing HRT. So choosing, and there's lots of us that are aware of, but choosing somebody who's familiar is really important. And then, I've not changed my back slide there. Ignore those connections. I should have my email address on it, so I can share that if anyone needs me to. And there's just a couple of links and resources. In the UK, we've got NAPS, which is the National Association for Premenstrual Syndromes. It's headed up by Nick Panay and a chap called Michael Craig, who's a professor in London who's trained in, he's a bit of a hero of mine. He's trained in psychiatry and in gynecology. So he's doing a lot of the work that looks at the body-mind connection. And their website is pms.org.uk. And there's an international PMD society, which is actually IAPMD. I think I've just misordered it there. So the International Association of PMD.org. And the bottom one is a cycle diary for those that want to download a cycle diary. And I'll take questions if anyone's got any. I'll just come out of screen share.
Thanks, Angela. There's one that's come into the chat box.
Okay.
So from Jo, she's asked that she's started tamoxifen over a year ago and struggling with all symptoms. Are there any other options, as I can't take HRT?
Yeah, so I would look at optimizing a lot of the lifestyle. So I use biopsychosocial approach. So I tend to sort of say, let's do what's in the body, let's look at what's happening psychologically, and let's look at your kind of wider environment. And although having hormonal treatments wouldn't be an option for you, the SSRIs might be useful for you. So that would be one option. We'll be looking, if it's acceptable to you, to look at an antidepressant, it can help. But some of the other things like the agonist castus, the supplements, the dietary changes, some of the psychological support, all of those things can be really helpful. And with cancer history, that's a trauma history. We often overlook the trauma of the diagnosis and the treatment. So doing some direct work on the trauma of that can also help a lot as well.
Thank you. It's really helpful. Thanks a lot.
Thank you. Is there any other questions? Does anybody want to take themselves off microphone and ask a question, or raise your hand, or pop it in the chat box? We've got some time for questions if you'd like something specific answered. So we've got
see more bits in chat. I was going to say, have you seen those in there, Gersh?
Yeah, so one's just come on now. Says, I've tried various HRT products, but not found one that helps. Been on LS, solo for about 2 months, but still not noticed any difference. Is it worth upping the dose?
Yeah, so LS solo is estrogen on its own. It's oral estrogen. So one comment is just, it might be that that's your choice, but transdermal through the skin estrogen as a gel or a patch or a spray doesn't impact clot risk, doesn't impact stroke risk and gallstone risk, and oral HRT does. So you might want to make a switch to transdermal. But your dose may not be high enough. So some women need more estrogen. You're not on, by the sound of it, a progestin, which might be because you haven't got your uterus anymore, or you might have a Mirena. But we would go higher. Upping the dose could be useful. And like I said, I feel like because women get, and they do get fobbed off with antidepressants rather than HRT, but we forget that the antidepressant and HRT option can be really helpful for some women too. I've got a direct message, and I won't read out sort of the details of it really, but I can respond. I'll respond to that lady afterwards because it's just been directly through to me, but I can't do it while I'm talking.
Okay, no worries. And just off the back of the last question, Sarah had said she's tried the transdermal and patches, but they don't work. She does have a Maria coil, and she's also on SSRIs.
On SSRIs. Okay, so A couple of things. Women don't always absorb. So one of the things with the transdermals that I find is that some women can stick on patches and nothing goes in. So that's maybe what happened, that you just didn't absorb it through your skin properly. So being on the oral dose is okay, but you're still getting, the problem with it is you get fluctuations. So every morning your level is up and then over the day it drops before you have your next level. So if I was treating you, I'd be probably inclined to have you on a high dose patch and do your bloods and check you're absorbing, and then titrate that patch higher to make sure that you were at a level that was working well for you. If you stay on taking an oral HRT, you probably need a higher dose than the dose that you're on. So lots of people stay at 1 milligram, but it's fine to go to 2 or 3 if needed. And different SSRIs have different impacts. So fluoxetine can actually worsen irritability and rage. You might do better on something like citalopram or sertraline. So they're not all the same in terms of issues and kind of side effects.
Thank you. Another one that's come in says, where there is no pattern to bleeding, not a 28-day cycle, is it better to try non-medical options first?
So if that's about mood, it would still be, there are conditions like PCOS or just being perimenopausal where you're not going to ovulate regularly. But if you notice a reproducible pattern where your mood is negative and then it gets better a few days after bleeding, that would still count, and that would still be amenable to the things that I've talked about. So effectively, you just want to stabilize through the month, a good level of estrogen and a low and steady state of progestin. So you could do that. There's not a lot of evidence for the non-medical options on their own, because this is biochemical. If your mood's fluctuating because of hormones, it's quite difficult to do behavioural things that are adequate to offset that if your symptoms are severe. So you can certainly try exercise and diet and supplements and so on. And if that works, that's fantastic. But often people need to regulate hormones to make it feel easier. Thank
you. So they're coming in now. So somebody's asked about, are there any menopause clinics available within this area? Jo, we'd probably need to work out whereabouts you are.
If it's Hull area, that's where I'm based, and there's several of us that do menopause and PMS and PMDD. So the Wilberforce is one for people that are kind of to the east of York, really. We take referrals.
Okay. Next question is, I had PSD after my son was born.
Yeah.
Premature 5.5 years ago. Could this have contributed to my struggles with depression and current struggles with perimenopause? I'm using Sequievral.
Yeah, I can read it as well on here. So Sequievral patches, only on to second month.
So I think I need to try a bit longer. I also take flaxetine. I'm currently struggling with bad joint pain, where we are not sure is
rheumatoid arthritis. I've got you. So yeah, in answer to your first question, yes, the overlap between trauma and depression is massive. And like a lot of these things that I've ended up getting involved in, it's like we see the tip of the iceberg. We totally underestimate the impact of lived experience on people's mood and and their sort of psychological health. In fact, worse than that, we tend to make psychiatric diagnoses for things when actually we're just responding quite reasonably to stuff that's happened. So massive overlap, and doing some work on your trauma might really help. It doesn't need to be talking help. It can be EMDR, which is a sort of eye movement desensitization. We do somatic work at the trauma centre. So sometimes body-based work is really good, because trauma is often stored bodily in muscles and so it's really interesting when you look into trauma in detail. But yoga-based therapies, tapping, breath work, all of that stuff can massively help. So I would encourage you to do that. The SSRI that you're on is fluoxetine, so it may not be the best one at the moment. Might be worth moving to something like citalopram or escitalopram. And your dose, you are on a Sequi patch, which means you're still cycling. You're doing 2 weeks of estrogen on its own, 2 weeks of estrogen plus progestin. And if you're sensitive and you can map a pattern in your month that in the second 2 weeks your mood is not as good as it is in the first 2 weeks, you may need to talk about steadying that out. So rather than having cyclical HRT, moving to a form of continuous HRT, which might mean a Mirena, or it might mean having to do something like Prostat to override and then add back continuously.
Thank you. Another one that's come in, I've been taking antidepressants and Lucette for 4 months. I've noticed different and the best I have felt, but just prior my off week from taking the pill, I start to feel a bit more anxious with more symptoms too, and it progressively worsens when I'm not taking the pill. Is this normal, or is there more I can do?
Yeah, you don't need your off week, basically. So the pill was designed in the 60s, and the week off is known as the Pope rule. It was only put in place because we couldn't get the pill past the Catholic Church. So they gave us a week off so that it would look like everything was much more natural and normal, and that's how we got it in. And we still have pills that work with a week off, a 7-day off, which is literally no use to women whatsoever. And in mood related change, it's a nightmare. So what I would do for you is try cycle your Lucette 3 months in a row, and then a 4-day gap only, and then another 3 months in a row and a 4-day gap. And that should significantly improve how you feel. And there's no harm in not having those bleeds. It's just you're stabilizing the womb lining, then you're letting it bleed, and then you're going back on again. And it's actually more reliable from a contraceptive perspective too. The off week is the problem.
That's really interesting.
A lot of the science around why we do stuff, the new pills that are coming out are better. They've got 4-day gaps and some have got none. We're increasingly moving to gap-free pill use because it's more reliable, but it's way better for symptom control. You know, menstrual migraines, people who get joint pains, back pains. I mean, we have so many miserable symptoms often with our bleeds, and we don't need to have them if we're on the pill. It's just this historic thing.
Thank you. So I think it was to go back to Joe's question about the clinics available. So she's around the whole area.
Okay.
And somebody's asked about a question around the North Yorkshire. So I suppose it's Humber and North Yorkshire as a whole.
Yeah.
Be able to suggest any clinics that you...
So Hull, we've got ours. We've just, so that's at the Wilberforce Centre. You can go under general gynae or community menopause. I think at the moment there's a pause on referrals, but after Davina, we got a 650% increase of referrals. So the system's kind of got drowned and we're just catching up, and then it'll open again. In North Yorkshire, that's where my GP surgery is, and I'm just working with the CCG to the north of us. We're just about to open Women's Health Hub in extended access in the Heartbeat area. So that's going to be menopause and PMDD. And gynae, some gynaes have got an interest in this. It's really niche. I hadn't realised like how little people understand and treat on this stuff. So there's not as many clinicians doing it as should be, which is what we opened privately to do that, partly for that reason, because there's just so few people that kind of treat it.
Thank you. So somebody's just putting the question in the chat box, sorry, that your answers are really interesting. Thank you for that. I've tried, I can't even say that.
Citalopram.
But basically went to bed every night feeling so drowsy.
Yeah, I mean, SSRIs are really individual in whether they suit people. And I get loads of women that just don't like how they feel when they're blunted at both ends. So it is about matching it to the person, but a lower dose or a different one, then they're not all the same. I think we think of sertraline, citalopram, fluoxetine, venlafaxine as if it's all kind of interchangeable, but they all work slightly differently. So it can be worth just trying different ones on the size, or a lower dose, or changing your dosing regimen to a different time of day, and you might do better.
Brilliant. And also a question about, can you see a menopause specialist on the NHS, or do you have to pay?
You can see them on the NHS, but there's not as many of them as we need. We're trying really hard to kind of increase training numbers. So in Hull, you've got us at the Wilberforce that have several menopause specialists working there. There's not anything formal in North Yorkshire, even though I did try and get my local CCG to kind of do something, but doesn't exist yet. I think Leeds has got a team as well. So a lot of the information that I'm giving is available through that NAPS website. So if you take those guidelines in and speak to a GP and just get them to prescribe according to that, that can help. But if people struggle, that's so one of the reasons why we did set up privately, because we knew there weren't many people around that did it. So there are people that work in both settings.
Brilliant. And just to follow on from that one, I think she's also said, is there anyone in North Lincolnshire?
So there's my lovely friend Hannah Short, who works in Lincolnshire, but she has currently closed her list because she was drowning, so she ends up referring to us. So there are, and I think she's about to start working within a local breast clinic as well. So for PMS, PMDD, it's really small numbers. We've actually joined a group, a big MDT, well, a group between us to try and share research and support each other, because there's probably less than 20 kind of people that have got an active interest in it in the UK, but it's increasing. We're trying to kind of spread awareness.
Brilliant. Thanks, Angela.
Someone saw me on here. There's one about they're happy for me to say out loud, but not say name, I think, with a question. So I might be able to use that one if you haven't got another one.
Yeah, no, that's it from the chat box.
Okay, I'm just going to try and read this one out carefully. So I've got somebody who's had a hysterectomy for other reasons, not PMDD, who's on 125 of Everel, not having flushes, feeling blah, might be life and stresses, but asking me whether or not testosterone is useful. So testosterone and mood are not things that we have got loads of research around. If you get the right level of testosterone, all you're doing is mimicking what you would have had in your fertile years. If mood, what I normally would do with somebody like you is actually measure your blood levels, because 125 of Everel for one woman can be very different to 125 on another. So I'd want to know how well you're absorbing it and whether you're where I'd want you in the range. The range is something like 250 to 800. And I can't even begin to kind of explain the huge variation in different people's absorption of different products. So if you were absorbing enough that your levels were sort of 300-400, I probably had testosterone. But if I did your levels and they were lower than that and at the bottom, and I get women who are on that kind of a dose who are at 100 or 200, then you need to change to a different product. So probably, and you need your bloods doing for testosterone anyway, because we normally want to check you've got adequate estrogen and make sure you haven't got a naturally high testosterone before we give more. And it is available on the NHS. She said she's aware it isn't available on the NHS. It is if you've got a doctor that's happy to prescribe it off license. So, my NHS patients in GP, I prescribe it to. I prescribe it NHS in the menopause clinic. An increasing number of GPs will prescribe testosterone if they've got an interest in menopause, and there are guidelines from the British Menopause Society to guide that process. So if you shop around, you might be able to find somebody that will do that on the NHS. Someone's asked if we should have bloods taken routinely. No, I mean, it's meant to be about symptom control. My practice is if I increase you to the top of the dose range before I would decide to do bloods. So I wouldn't do bloods routinely. I'd just step you up to the next level. But if you get to the top of the level that's licensed, then I tend to do bloods, because I get women that aren't absorbing. That's a specialist thing to do. I don't think you'd often get your sort of standard GP being happy to do that on their own. And that's because we've got a massive gap, I guess, between what would be desirable to do sometimes and and then there are private specialists who do bloods all the time, and I think that's probably not needed either. So it's only if you think you're not absorbing, and if a woman has gone all the way to the top of a dose range and has not had good symptom control, you can change product, or you can do bloods first and then sort of see whether it's really that or not.
Brilliant. Thank you. I think that's the end of the questions in the chat box. Is there anybody else?
I've got a direct one, but not with a name. So I've just got somebody who's asked me a question about sex drive and what to do. So the question is just, my sex drive is non-existent now. What can I do to increase this? And my testosterone level is very low. So did you record the sexual function one that we did? So I go into massive detail on that one, because testosterone is important for people whose sex drive is low at menopause. first thing to do is to get your estrogen level adequate. Second thing to do is to get the estrogen vaginally and vulvally where it should be, so that touch is sensitive and good, and you respond and so on. Then testosterone. But there's an absolute ton of other stuff that impacts women's libido at this point, like stress, distraction, trauma, long-term relationships, body image, you know, a gazillion other things that impact as well, which I think we went into in more detail on the other webinar. So if you can look that up, that might give you some idea.
So I've just put the link in
Fab.
so through the Menopause Festival, we've recorded all the sessions and they're in a bit of a playlist, excuse me. So if you click on that link, it'll take you right through to all the sessions, so you can click on the one that you'd like. That's great. I think that's it for questions. Is there anybody else who would like to come in? We've got a minute or two.
Yeah, I'm more than happy.
Yeah, if that's it then, thank you very much for joining. And again, thank you, Angela. You're always really insightful and teach me too. But thanks everybody. If you've, we will be sharing the recording. I'll ask Angela permissions regarding the slides a little bit later. And any other sessions that you'd like, you can obviously book on through our book when session where you booked onto this session. Thanks everybody for joining and take care. We'll see you again soon.
Thank you.
Thanks.